Hi, my name's Lisa Collison, and I'm a registered nurse and program manager for APNA, the Australian Primary Healthcare Nurses Association. I have worked for more than 25 years across multiple primary healthcare settings, spanning both rural and urban locations in a variety of management, clinical, leadership and program roles. And I have a strong commitment to supporting and raising the profile of nurses working in primary healthcare. Today's presentation is describing work undertaken since 2015 in primary healthcare in Australia and the utilisation of the primary healthcare nursing workforce. Nurse clinics or nurse-led clinics exist in a multitude of healthcare settings and across multiple jurisdictions, both nationally and internationally. In Australia, nurse clinics provide an exciting opportunity to refocus the delivery of evidence-based, best practice care for a range of population health needs in primary health care, while building capacity in the primary healthcare workforce. This presentation provides an overview of the barriers and key characteristics of successful nurse clinics based on the evaluation findings of nurse clinic participants across several programs. So who are APNA and what is our mission? Our mission is to improve the health of Australians through the delivery of quality and evidence-based care by a bold and vibrant primary healthcare nursing workforce. Our Nurse 2022 campaign runs from 2018 to 2022, but in reality, we know that this is lifelong. Our pledge is to be valued, visible and respected as a part of the nursing workforce. This aligns with the principles of the Nursing Now campaign, seeking to empower nurses. Let's get on with it. So how good is good? Team-based, nurse-delivered models of care, or nurse-led care, is a continuum of practice, ranging from the nurse having delegated authority to make decisions regarding patient care at one end of the spectrum, to being responsible for all care provided, including clinical assessment, treatment and management of patients undifferentiated by their needs. It's not a new concept, as we said. Nurse clinics or nurse-led care exists in a number of ways, both nationally and internationally. This presentation will provide an overview of the barriers and key characteristics of successful nurse clinics based on the evaluation findings of our nurse clinic participants. We will explore why did it need a spotlight at all, and we can have a look at what we did, what we learned, how we did it, and then next minute, fire, floods and COVID. Let's get started. So, why did we need to put a spotlight on this particular issue when there are so many? Well, because we have challenges with the primary healthcare nursing workforce in Australia not being enabled or well enough supported to work to top of their scope of practice. And that will in turn allow nurses to move into areas where nurse-led clinics or nurse clinics can be built around core community needs. So it's a problem. And how do we know this? Well, apart from daily interactions with nurses throughout Australia, we also conduct an annual workforce survey. Again, in 2019, a significant number of nurses reported that they could and wanted to do more in their workplace. They wanted to do more with their skills to contribute as part of the healthcare team. It's concerning that 45% of respondents felt that most of the time their skills were not being fully utilised. More than half, or 52% of nurses surveyed, had approached their employers suggesting a more complex role or more activities based on their education, training and qualifications. Of these, only 30% were successful in negotiating more complex tasks or extended roles. And 30% had the suggestion declined, while 40% was still waiting for a decision. We guess it might be in the mail. This continued underutilisation of primary healthcare nurses is a significant lost opportunity for our nation, and it's an issue that APNA remains focused on. The Career and Education Framework for Nurses in Primary Healthcare is a significant issue, as nurse-led models of care required appropriately skilled and knowledgeable workforce. And although nurses do feel undervalued in primary healthcare, or primary healthcare may be seen as a secondary choice for nurses coming into the nursing workforce, those who know and who work in the area know how valuable it is. Also, the funding mechanisms for primary healthcare in Australia are quite complicated. Broadly, Australia's health system is a complex mix of government and privately funded services delivered in a variety of settings, and all of that would actually be a whole day workshop in itself. So if I can put it simplistically, there is block funding, bundled payments, flexible funding, and blended models. There's also a fee-for-service funding called Medicare Benefit Scheme, or MBS, which predominantly financially remunerates and supports the work of the medical practitioners rather than the whole healthcare team. Because of this, nurse-delivered care is financially palatable in some areas and not in others. For example, a nurse clinic within a prison setting is block funded and can be implemented much more easily than the exact same type of clinic within a general practice, which is predominantly MBS funded. So, of course, we all understand that financial implications are important, but it is a barrier for us here. Of course, chronic conditions being the leading cause of illness and disability and death in Australia is not segmented to Australia alone. I'm sure many other countries experience this as well. But we would ask, is better utilisation of the nursing workforce a solution? We think so. Also, there is evidence to indicate that there are substantial benefits to nurse-led models of care. And while the format of these clinic models may vary, the international evidence around nurse-led models of care, such as nurse clinics, shows us that this is an aspect worth continuing to build on. Why? Because there are positive benefits to nurse-led models of care, which include improved health outcomes for patients, and who doesn't want those, improved access and shorter waiting times, with decreased rates of hospital admissions, and most importantly, a holistic approach and a person-centred care model can be delivered. There are two key pieces of work around team-based nurse-delivered models of care, or nurse clinics. Both have been undertaken by APNA under the Nursing in Primary Healthcare program, which has been funded by the Australian Government Department of Health. Both have aimed to demonstrate and provide replicable models of best practice in primary healthcare nursing through implementing a nurse-delivered, team-based model of care, and to build on the capacity of the primary healthcare team by optimising the role of nurses in care delivery. And the work is continuing. So what did we do, and what are we continuing to do? Firstly, we got the nurses involved through an application process. That was taken with high interest throughout Australia. Lead nurses had to apply and describe their model and provide a budget for that model. Seed funding was provided to successful applicants with stipulations around how it could be utilised. For example, they weren't able to use it for paying wages, as that was seen as part of establishing what could or might not be sustainable. A service agreement was entered into with the organisation and the lead nurse because, after all, it's team-based. Data collection frameworks were established and differed depending on the clinic type and the setting it was set in. An induction workshop was held to educate and support the process. Project advisory groups were established, and mentoring and support was provided to lead nurses by experienced primary healthcare nurses. Across all, there's been an exploration of the key characteristics of the nurse-led clinics in a range of primary healthcare settings across metropolitan, rural and remote Australia, and that continues. We have explored the work of nurse clinics both nationally and internationally through a comprehensive literature review, and we've explored the barriers and enablers and identified key structural elements to commencing nurse clinic work. With an evaluation framework in place, a growing knowledge of the challenges and opportunities that contribute to successful nurse clinics is being developed. Demonstration of success is based on the measures of feasibility, acceptability, effectiveness, efficiency and sustainability, including financial viability, replication and the perception of the value of the nurse clinic model. 8 elements or building blocks were identified as essential components of establishing a nurse clinic. The building blocks are designed to provide a modular and flexible and replicable approach to establishing a nurse clinic, rather than attempting to create a one-size-fits-all model. These elements continue to be explored in the continuing work. We examined nurse clinics across the following domains. Feasibility, were they established? Acceptability, what did stakeholders think about the nurse clinic? Effectiveness and efficiency, based on a series of clinic-identified processes and sometimes outcome indicators and key stakeholder perceptions. Financial viability for a select number of clinics. Sustainability, looking at perceptions of nurse clinic sustainability and intentions to sustain. So let's take a look at each of these elements now. Let's firstly look at financial viability. There were 3 core determinants of sustainability relating to financial viability. A small portion of clinics were evaluated by a health economist to examine this aspect. If we first look at revenue, we'll see that nurse clinics that operated under block or blended funding were more likely to be sustainable, meaning that the nurse clinics which apportioned block funding towards their clinic budgets were more likely to be viable than those that relied on fee-for-service funding alone, such as MBS item numbers. Nurse clinic activities such as planning, quality controlling, problem solving, and being agents of connectivity between different disciplines within health services and between patients and the health service are not typically funded through the fee-for-service funding model. The block funding available to other nurse clinics was the Practice Nurse Incentive Program, now called a Workforce Incentive Program in Australia, that is available on application through the Australian Government for eligible practices or workplaces. This funding was originally intended to optimise better utilise the primary healthcare nursing workforce and has now been expanded to the other disciplines. None of the general practices were required to monitor a specific nurse clinic budget in any great depth, and none had considered that the allocation of this particular funding towards nurse clinic activities was relevant. This is usual in general practice in Australia, where the government funding is regarded as a welcome payment that helps, recuperate staff costs without being really allocated towards specific kinds of patient services. It's one of our gaps. What about billing practices and holistic care? Only one of the nurse clinics that was evaluated actually charged patient fees. Additional clinics are currently being evaluated under that particular model, but that evaluation is not yet available. These fees were both for nursing services and for the general practitioner services that were part of the nurse clinic service. Private fees accounted for 40% of their total remuneration and were the largest contributor to viability. The other nurse clinics had been able to had clients who were, in the majority of cases, would not have been able to afford a private fee, and so it was not seen as something that they would like to do or should do. It was clear that most nurse clinics had not carefully considered innovative approaches to bringing in more revenue to support their nurse clinics. These could have been, for example, the introduction of small nursing fees for services for certain clients that met income tests, or a one-off nurse clinic entry fee, or working with local community organisations or organisations to source donations. Nurse clinics could test and innovate fees policies in order to support their activities. Additionally, the majority of private general practices pay their GPs a set percentage of their Medicare or MBS revenue. And so for every item claimed, irrespective of the percentage of the time that the GP or the nurse spends on patient care in relation to the particular claims, is paid. This puts the clinic at a financial disadvantage where the clinic is paying for the nurse to be engaged or employed, and the nurse is doing the majority of the work in some cases. And how about articulating the non-financial value of a nurse-delivered service? Well, being able to articulate the value of the nurse clinic was a key predictor of whether a nurse clinic model would be sustainable. Value is attributed to 4 key areas. They are improved patient engagement and outcomes, reflected in better rapport and trust between the nurse and the patient, and the provision of care that is patient-centred or person-centred, and preventive rather than reactive, planned rather than reactive as well. Systems and processes that were introduced by the nurse clinic, which increases the efficiency and reduces the duplication of effort, increased autonomy of the nurse, impacting on job satisfaction, and we all know about the quadruple aim and the clinician's experience, as well as an opportunity for the nurse to take on a leadership role. So let's take a look at feasibility. The key points are that nurse clinics need to have the following criteria. They need to meet a local population health need. They needed to have an evidence base. They needed to have available and appropriate staffing and clinical expertise. They needed organisation support and key stakeholder support. Acceptability was reflected in the following areas. Where the clinic was located in a general practice, the general practitioner needed to have confidence in the model, and they needed to have trust in the clinical expertise of the nurse to undertake the care required in the clinic. From the practice manager's perspective, they also needed to understand and have confidence in the following factors that sat around the nurse clinic model. they needed to understand the capability and capacity of the lead nurse or the nurses, the impact on the patient care and the team, and the cost related to the nurse clinic. Community support for the nurse clinic was greater if it was seen to be meeting an unmet need. External stakeholders, such as a subject matter expert or a specialist, supporting a model of care which improves care delivery and the patient's access to care, was also pivotal. Patients reported an increased level of encouragement with their care and a higher level of patient satisfaction in engaging with the nurse clinic. So let's now look at effectiveness. Effectiveness data proved to be the most difficult parameter to collect, and it continues to be so. While some nurse clinics were able to collect a range of clinical data, the majority of lead nurses reported having lack of time and/or the lack of support required to do this aspect. All nurse clinics were required to submit a range of data over the course of their involvement in the project, with each clinic supported early in the project to develop a clinic-specific minimum data set that would be utilised throughout the time, and would provide useful information across a number of dimensions, including things like patient throughput, referral rates, clinical data, MBS item numbers, and quality. Regarding patient activity, for the majority of nurse clinics, patient activity data of the number of patients attending was well recorded, providing an indication of patient engagement and with the nurse clinic, and supported by comments by the lead nurses and data collected in the Patient Satisfaction and Enablement Survey, or PES, which also provides evidence of observed effectiveness and efficiency and efficacy of the nurse clinic model. The clinical outcome data was also difficult. A range of clinical outcomes data was collected across a number of domains, including things like cardiovascular disease risk and biometric data such as glycated hemoglobin, etc. So as an example of meaningful clinical outcomes data, for example, in a 4-month window period for one of the clinics, 71 patients were seen, with 64 returning for a 3-month review, or 90%. That's a 90% return rate. And this cohort showed an 80% improvement in their HbA1c in those patients with a HbA1c of originally over 8. So you can see the implications of this type of thing. Even though it's a small example, you could see the implications of improvement if it were you had a targeted patient population and you were undertaking some of this work. The findings from the consultation process indicated the need for a flexible approach to setting up a nurse clinic. Following the consultation, the suggested content was ordered into a series of 8 building blocks. These are essentially a blueprint for how to set up a clinic and could be called a blueprint of nurse clinics business model. Each building block contains key components for setting up and running a nurse clinic. The building blocks provide a flexible framework, a modular and replicable approach to establishing a nurse clinic rather than attempting to create a one-size-fits-all model. Use of the building blocks enables the development of models that suit the local context and account for factors such as community need, staff availability, expertise, and organisational capacity, and reinforce the concept that there is no single approach to setting up a nurse clinic. So, what did we learn about the key barriers to nurse clinics in Australia? These have been themed into 3 categories: the nurse, the organisation, and the system. Firstly, let's look at the nurse. The key learning here was that the burden of establishing a nurse clinic simply cannot be the sole responsibility of the nurse. We actually need the team. Barriers for the nurse included a lack of effective management support and leadership and team engagement, lack of protected time, lack of project management and budgetary skills on the behalf of the nurse. If we had a look at the organisation, the key barrier for the organisation was that they were missing key factors essential for nurse clinic success. There was a lack of internal and external stakeholder engagement. There was no perceived organisational leadership. There was lack of collaboration and team engagement. There was staff turnover during the project, and both lead nurses and practice staff, and lack of role delineation between the nurse's clinical tasks and administrative support. There was difficulty collecting data from practice software and a lack of confidence in its accuracy at times. There was also the patient cohort within the organisation was a key barrier. For example, those organisations with low socio-economic statuses of their patients that could only tolerate MBS billing. And finally, the system. Key barriers that were found was that the system was resistant to change. There's long-standing systemic and cultural conditions, especially within the general practice setting, which make the shift to innovative nurse-led models of care really challenging. There's also commercial concerns, and the financial viability of nurses and nurse clinics in the general practice in particular, who do not have block funding, was a key concern for both general practitioners and the practice managers, impacting on their wider adoption. There was also lack of confidence and awareness in the clinical abilities of the nurse. So GPs were more likely to support the lead nurse and the nurse clinic concept when they were confident in the clinical expertise of the nurse and really understood the nurse clinic model. So if they were part of the team and engaged, then there was a greater success rate for those. Let's now look at the nurse clinics within the general practice setting in Australia. Encouraging the uptake of nurse clinic models within the general practice setting in particular continues to be hampered by the funding model. This is because of the activity-based nature of Medicare Benefits Scheme, or the MBS billing. Working autonomously in a general practice by nurses is difficult in regards to presenting a viable financial case, as the majority of MBS income in general practice is generated from direct GP interaction with the patient. Healthcare homes or other so-named models and trials have been attempted and not yet accepted within the Australian community, not so much by the actual community themselves, but through the general practices community, because they haven't yet provided palatable models that can be broadly taken up. In the past year, Australia has faced several major public health crises that have required large-scale government interventions, crises that have further highlighted how important health is to our quality of life and overall well-being. In the aftermath of the 2019 and 2020 bushfires and floods, and now the ongoing management of COVID, as you are all aware of, governments and policymakers have the key challenge and priority to develop and implement evidence-based policies, as this is crucial to ensuring that health systems respond effectively to current and changing needs. On the matter of COVID, APNA has been surveying primary healthcare nurses since March about the impact of COVID-19 on them and their patients. A pulse check survey was used in a regular way to check in with nurses on the ground in primary healthcare after lockdown restrictions started, seeing the unintended consequences for healthcare providers in the community. Cracks started appearing when many patients stopped going into their general practices, scared that they would either get sick in the waiting room or assuming that clinics were closed. With less foot traffic, a significant number of health services began cutting staff and clinic hours. Hundreds of frontline primary healthcare nurses and other staff have borne the brunt of this, with redundancies or reductions of working hours. Within the nurse clinic programs, we've found a number of impacts from COVID, with lead nurses unable to see patients in their clinics, and meaning the throughput was significantly reduced. That meant that had a flow-on effect on the data collection with the biometric, the patient enablement and satisfaction surveys, the patient activation measurement surveys, health coaching, etc., being impacted. Work was also redirected at increased presentations for influenza-like illness or influenza vaccination, as that was the key time frame here in Australia. Some nurses did investigate and successfully implement a change to their nurse clinic model, with changes in telehealth and the use of telehealth. For example, health coaching and care planning via telehealth was undertaken. However, due to the funding model, even that proved difficult, even though nurses did still continue to provide it through that technology, regardless of the fact that it wasn't remunerated in many cases. Many clinics could not go back into operating as intended. For example, those nurse clinics who had a patient cohort, such as the homeless or the ageing or other vulnerable populations, it just wasn't reasonable or realistic to undertake that work with those patient cohorts. Even though in June there was a reignition of activity depending on the clinic type and the location of the clinic, because different states and territories across Australia had different levels of closure, it still was very slow with that hiatus happening and just getting the ball rolling again to get their clinics happening. Adapting to the changes and challenges of COVID and the pressing need to undertake other activity within the clinic in a different way had become a focus for many of those within nurse clinic. Some of the participants and applicants have had employment impacts like reduced hours and reduced prospects of employment. So with lead nurses having their hours reduced or losing their employment, that has an impact directly on the nurse clinic itself. Still, all of this reinforces the barriers that Australia has in adopting and moving forward with innovative models of care, such as nurse clinics in Australia. So, in closing, you can see we have a long way to go, and we have some significant barriers to innovative nurse clinic models within primary healthcare in Australia. But outside of the funding model for general practice, there is some great innovative nurse-delivered team-based care models that are positively impacting our communities. And we are confidently building resources that can support and assist nurse clinics in whatever funding model they operate in. Thank you for listening. Bye now.